Hello and welcome to the Lancet Pulse. Now, I'm a voice you haven't heard before on this podcast. My name's Niall Boyce, and I'm one of the senior executive editors on The Lancet, and I'm joined by my colleague Matt in New York. Matt.
Hi, Niall. Thanks for inviting me to join you on this podcast today. I'm Matt Gilbert, the North American Clinical Acquisition and Outreach Editor, based here in New York, as Niall just said.
Thanks, Matt. So today we're going to be talking about diet and mental health, and specifically the keto diet and bipolar disorder, about which there's been much excitement over the past couple of years. Now, Matt, how much do we know about bipolar disorder? I think because we have a general listenership, it might be worth taking a few minutes to say what it is. Clearly, it's a mental health problem. And it's a mental health problem that's characterized by fluctuations in mood. So people with bipolar disorder can feel very energized, almost too energized, and sometimes behave in ways which they wouldn't otherwise, which can be very reckless and which they then regret. And then that's what's called the manic phase. But then the other side of bipolar disorder, there are long periods of really difficult depression, which is very hard to live with, and from the clinical point of view, very hard to treat. Now, the mainstay of bipolar disorder treatment, there are two things which people use, one of which is medication. So medications such as lithium, which if taken consistently can really help to stabilize mood. There are also psychological therapies. But today we are talking about dietary therapies. Now, how much do you know about this, Matt?
Only what I've learned in the past few days in anticipation of this podcast. But of course, lifestyle modifications can have a big impact on all types of health, with mental health, of course, being included in that.
So we're very lucky that we have an expert, because I must admit this is totally new to me, the idea of controlling bipolar disorder with diet. So we're joined by a guest. Daniel, would you like to introduce yourself to the listeners?
Hello, I'm Danny Smith. I'm Professor of Psychiatry at the University of Edinburgh, and I have a special interest in bipolar disorder. Very recently, my main interests have been circadian neurosciences in relation to bipolar, and then, of course, nutritional interventions for bipolar.
So let's talk about nutritional interventions. Now, the keto diet is a very specific type of diet, and I wonder if you could describe what it is.
So the keto diet is essentially a very low-carb diet. It tends to be low-carb, high-fat, and moderate levels of protein. The proportions of that are usually something like 70% of calories from fat, 20% from protein, and then less than 10% from carbohydrates. So it's quite different from regular other diets, I guess, and it's quite challenging for many people. So it involves lots of eggs, cheese, butter, meat, fish, not so much vegetables, not so much in the way of fruit. And people need to be careful with it, for example, in terms of making sure they're not dehydrated and that kind of thing. So it can be challenging, but as we're about to hear, some people find it helpful in different ways.
And it wasn't developed for bipolar disorder, was it? It was developed completely differently, I think, for physical health.
Yeah, I think it's still used quite a lot in the obesity world and in diabetes. It obviously increases insulin sensitivity and helps people to lose weight. So it's quite effective at doing that. And it has a long history actually in the world of epilepsy. So going way back 100 years or more, the ketogenic diet has been used for pediatric epilepsy that hasn't responded to medication. And indeed, there are services all over the UK and indeed all over the world specialising in pediatric epilepsy that deliver ketogenic diet as quite an effective treatment. And there's now good systematic reviews and randomized controlled trials of the usefulness of it in epilepsy. So yeah, it's kind of, that would be the people that we've got involved in our work have come from the world of pediatric epilepsy, actually, the nutritionists that are now involved with us.
Well, I was just going to ask, when did the ketogenic diet draw the attention of the larger psychiatric community and move beyond epilepsy?
So it still hasn't drawn the attention of the wide psychiatric community. It's still quite a nascent niche area, I would say. There were case reports published probably 20, 25 years ago, one or two case reports. And then it went, nothing much was published on it after that for a while. I would say in the last 5 or 6 years, a lot of interest has been gathering momentum because of new case reports in bipolar, but also in schizophrenia. Case reports as well as case series, but nothing in the way yet of really good randomized controlled trials. And also I think it's fair to say there's been a kind of groundswell of interest, thanks to the internet mostly, from the people with lived experience of bipolar who've tried out the keto diet and found it helpful in different ways. And I think that has helped raise the profile of it. And of course, philanthropy have invested in studies and getting studies off the ground, which is quite interesting as well, because for example, we tried to get a trial of keto funded about 4 or 5 years ago, and we were told point blank, there's no evidence here, there's nothing to see here, it's too early, it's very speculative, etc., etc. So what's happened is that philanthropic funding has filled that kind of space and really helped move the field forward. And now we're able to, report on feasibility studies and then do trials that are funded by conventional funders, research funders. So I hope that answers the question.
No, it's fascinating because with most mental health treatments that we have now, so whether you're talking about lithium, of course, famously discovered in the late 40s for bipolar by John Cade, whether you're talking about antipsychotics, whatever therapy you're talking about, most of the time in mental health, we've got the agent, we've found out it works, but we don't know how it works. That's proved much more challenging. With keto diet, is there any idea of the mechanism by which this thing might stabilize someone's mood?
So there's lots of ideas about potential mechanisms, but whether or not those are true needs a lot more work. I think in a general sense, there's a prevailing view that ketosis rather than glycolysis, so if you get your energy from ketones on a ketogenic diet rather than burning carbs and getting it from glucose, that's a much more efficient way to get energy to brain tissue, and you get much more bang for your buck in terms of ATP and the energy molecules. So I think there's a general idea that a brain that is in some way compromised or even subtly functioning not optimally, as might be the case in severe mental illness, that those brains might do better with a more efficient way to access energy. So that's a very general idea. But of course, there are other ideas related to that. For example, mitochondrial dysfunction. So that may be a feature of bipolar disorder, and it might help mitochondria to function more efficiently. And then there's ideas around neuroinflammation, ideas around neuronal growth factors that can happen. And there's even thoughts about the brain-body axis in terms of the brain-gut axis. So the microbiome may change on a ketogenic diet, and that could have effects on brain tissue. But I would say this is all still relatively speculative, and we don't really have very detailed, high-quality evidence of mechanism yet. But we're starting to get there.
Well, so along those same lines, regarding the early trials that you've mentioned, what beyond improvement in mental health symptoms would you be hoping to learn in these trials? Are there any particular imaging or biomarker results that might help to bolster further studies?
Yeah, so the trial that we're going to be starting this year, and that follows on, I should say, from a small feasibility study that we published recently of just 20 patients who went on the keto diet. They were clinically well with bipolar disorder, and we just wanted to see if this was feasible for them to take, and could we get the outcome assessments from them. In that small feasibility study, we did something called magnetic resonance spectroscopy, and we looked at different metabolites in the brain and how they changed before and after the ketogenic diet. And there was a small tentative signal, perhaps, that glutamate levels in the brain changed in mood regulating areas, but nothing very convincing, and we need to do this on a bigger scale. So what we're going to look at in our bigger trial called Energize BD is we're going to do magnetic resonance spectroscopy at baseline after 6 weeks of the interventions, and then after 12 weeks of the interventions when the primary outcome occurs. And we're going to see if there's anything like a trajectory of change in brain metabolites, like the glutamate GABA balance in the brain, but also things like lactate and also ATP even levels in the brain. So it may be that those brain metabolites are directly related to symptomatic response, perhaps. But again, that's just one potential mechanism, and there could be many others that we're just going to study that one to do a nice clean study. But if we had all day to talk about this, I would be mentioning things like sleep and circadian rhythms and how people report those changing when they go on keto. And I think it's very possible that, just like lithium, there could be many, many different types of mechanism of action, and that some patients get better on lithium for one reason and other patients get better on lithium for a different reason. And that seems possible in bipolar disorder, that might apply to the ketogenic diet. Some people might get better because of more of a neuroinflammation response. Other people get better because insulin sensitivity in the brain improves. So these are heterogeneous disorders, and what I'm trying to say, I guess, is that there's unlikely to be a single silver bullet mechanism. That may be a mixture of things.
And yours isn't the only group trialling keto diet for mental health, am I correct?
That's right. So there's now several groups around the world doing similar studies. So in Pittsburgh, the group there are looking at hypomania and looking at how brain connectivity changes in response to a ketogenic diet and hypomania. Some people are looking at first episode bipolar and first episode psychosis, and they're looking at metabolomic changes and neuroinflammatory changes as well. So yeah, there's probably 5 or 6 groups around the world doing reasonably sized mechanistic studies now.
And you said that there's been quite a lot of philanthropic funding in this area. Now I think that's great in many ways, because it takes these areas which would otherwise be considered sort of slightly out there or slightly risky, and it gets the initial data and it brings them to public attention. But isn't the worry then that people find what they want to find, what they expect to find? How do we separate the hype from the hope here?
Yeah, I think that is a problem, potentially. I think a key thing is that the philanthropic funder shouldn't have any role in the design or execution or reporting of the study. That's a very basic principle. I think that's important. But I think the key thing is that we do need properly designed, large, well-powered, randomized, controlled trials to demonstrate efficacy, and everything else isn't going to be as helpful as that. I'm not saying that everything else is unhelpful or unreliable. Everything is useful up to a point, but I think if you really want to demonstrate gold standard efficacy, you need a properly controlled randomized trial on sufficient numbers of representative patients, etc., etc. So, I think from my view, the philanthropy has been really important in getting the message out there, raising awareness, and funding these pilot studies. But I think we need to move on now to do this on a larger scale.
And is bipolar the condition in which these trials are the farthest along? Is this being investigated for other mental health conditions and for other, brain conditions beyond traditional mental health?
Yeah, absolutely. So there's actually a literature on things like Parkinson's and multiple sclerosis, and even to a lesser degree Alzheimer's disease, in addition to epilepsy, of course. So there are other neuropsychiatric conditions where this has been tried and is continuing to be trialed. Within psychiatry, there hasn't been as much work done, but people are trying it out for schizophrenia, for chronic schizophrenia, and also for other conditions. So migraine, even I think there's a study in California looking at eating disorders, which sounds counterintuitive, but there's a small study happening around anorexia, for example, which sounds challenging for obvious reasons, but it may be that this nutritional ketosis changes the appetite mechanisms in the brain and satiety mechanisms and reward mechanisms, and therefore could conceivably be helpful for that kind of condition. So it's being used on a small scale in lots of different psychiatric disorders. But I would say, yeah, that's correct, that bipolar is where all the focus has started and where that's much further ahead, yeah.
Now, we know that people sometimes find the medications which are prescribed for mental health problems really quite hard to take and quite hard to stick with. In the case of antipsychotics, which are sometimes used for bipolar, they can be very sedating and be associated with weight gain and movement disorders. We also know that lithium can be quite hard to take, so people have to have their blood tested. They can get a nasty sort of metallic taste in their mouth. So intuitively, I'd say having eggs and butter and so on sounds much nicer than that. But I do worry that the dietary interventions are quite hard to stick with over the long term. And these are long-term conditions. Bipolar is a long-term condition that people have very often for life. Do you have confidence that a dietary intervention is really something that could keep people well for years, potentially decades? And how do we manage the side effects of that?
Yeah, no, it's a great question. I guess our first approach is that we think it's probably got really helpful antidepressant effects in people with bipolar. So as an option as an acute treatment for bipolar depression, that seems like a useful thing to do. As an add-on to regular treatment, of course. So that's why we're interested in doing it for bipolar depression. I think those are very valid concerns about the long term, and it needs a lot of support. But, on the flip side, people have a little bit more agency about looking after themselves if they decide they're going to cook their food in a certain way and live and have a certain kind of dietary approach to their illness. That does give a lot of confidence around self-management. And I think as long as doesn't replace other really effective treatments like lithium, then some people will be able to stick with it, but obviously not all. I think it's worth saying in our studies and in the trial that we're doing, people do need a lot of dietitian support. So they need quite a lot of input from expert dietitians about how to cook and how to balance out the proportion of fats and carbs and all of these things. But once people learn those skills, they are kind of skills for life, aren't they? And conceivably they could go on for long periods if they decide to do that. I have met people who've been on this for 4 or 5 years or more and done it, but those are highly motivated individuals who are really keen on it. So I guess it won't suit everyone, but it just feels like a thing that we need to look at carefully, because it could be transformative at some level, partly because it shifts the conversation about what causes mental illness a little bit. So it's not possibly all about serotonin and dopamine. It may be about energy and how we access it and use it. So for those reasons, I think it's obviously worth pursuing. But yeah, we need to think carefully about how would you support people in the NHS, for example, in the long term to stay on this.
Yeah,
it's not easy.
And so to be completely clear from what you've said, you'd be visualising this as sort of an add-on rather than a replacement. And that's worthy in itself, because we know that even if you treat bipolar disorder, people have these terrible periods of depression, which are really hard to treat.
Absolutely. Yeah. And we haven't got very good treatments for depression, as you said at the start, Niall. I mean, this is the main area of need in bipolar research. Like, how do we get people out of, often terrible fatigue and lack of energy and lack of motivation that they're troubled with a lot of the time, even when they don't have full-blown clinical depression. Many people with bipolar struggle a lot of the time with low-grade amotivation, lack of energy, sleeping too much, all of these things. So, I think there's a potential for as an acute treatment, which is promising. But, if people can stick with it, there might be other benefits.
And if it becomes acceptable as a maintenance treatment, are there any longer-term adverse events that patients should be aware of? And would that impact its ability to scale and become applicable outside of high-resource environments, where people can have a dietitian and a PG and a psychiatrist and all that monitoring their progress?
Yeah, I mean, that's obviously a great question. So, it's not cheap, for example, to eat keto, I think that's fair to say, because of the kind of foods, whole foods that you're buying and sort of fresh meat and all that kind of thing. So there's potential for health inequality being worsened in that sense. In terms of tolerability in the long term, people, there has been concern about cholesterol levels and that kind of thing. I don't think we have the long-term data yet to really make a call on that. But, one thing we haven't mentioned is that one thing that people really like when they go on the keto is that they lose weight. In our little feasibility study, the average weight loss is 4 kilograms over an 8-week period, which is respectable. So just losing weight, if you have a severe mental illness, can have all sorts of useful benefits as well. So I think what I'm trying to do is to kind of balance out the kind of potential less obvious benefits that people might experience alongside We need to monitor things like, there's constipation. We have to be careful about dehydration. People should take a multivitamin, etc., etc. So it does need a reasonable level of support for sure.
Another thing I think which you mentioned earlier is that this isn't the only area of dietary intervention which is currently under investigation. And I think that we've really seen an amazing increase in recent years in interest in the microbiome, in inflammation, in the gut-brain axis. Some of this won't pay off, some of it will. But I wonder if you have any other areas of this this new and interesting form of intervention in mental health which you're investigating or which you're intrigued by at the moment.
Yeah, so we have in Edinburgh the UKRI hub for metabolic psychiatry, and one of the work streams in that hub is thinking about metabolic interventions apart from the ketogenic diet. And obviously there's a lot of excitement around GLP-1 receptor agonists at the moment, semaglutide, etc. It's changing the world in many ways, these kind of highly effective weight loss medications. And there's huge interest in psychiatry, I think, that's evolving. So we're really keen to do some very careful studies of GLP-1 receptor agonists in people with severe mental illness, both schizophrenia and bipolar disorder. I think that's really important that, very careful mechanistic studies are done for severe mental illness. So that's a big focus of us. So our colleagues, part of the hub for metabolic psychiatry, we have co-investigators in King's College London. So our colleagues down there, for example, recently conducted and are about to publish a priority setting partnership with people with lived experience to try and think about what metabolic treatments are they most interested in for severe mental illness. And indeed, right up 2 or 3 of the items in the top 10 questions are to do with GLP-1 receptor agonists. Patients know about these. Many patients are already on them. We need to work out, do they help things like psychosis and bipolar disorder? And how might what is the mechanism of that? And if that is helpful, how do we make that an option for people?
And from what you've seen so far, are there similar effects on positive and negative symptoms? And has there been any research into effect on substance use disorders?
Yeah, there have. There have been studies for, I think, alcohol and drug misuse using GLP-1 agonists. I think a lot of the data actually comes from routine healthcare data sets where people have been on them, and then you can look and see if it had any effect in the longer term. I think this week there was a study published from Sweden that seemed to suggest that individuals who were on things like semaglutide were less likely to get worse in terms of their depression and anxiety compared to people who were on different other anti-diabetic medicines. So the data so far in these areas like drug and addictions, I think mostly comes from routine data sets and health linkage studies. But yeah, there's huge interest in it for sure.
And how about for ketogenic diet? Is it similarly effective on both the positive and negative symptoms of mental health? Like you mentioned psychosis specifically, but also with bipolar, I assume it's shown efficacy in treating depression and mania. But then also for substance use disorders, you'd mentioned eating disorders previously. I don't know if that's in the same family.
So I think the honest answer is we don't have the data yet to say that it helps with psychosis and with positive and negative symptoms. There's a little bit of data in bipolar that might help depressive symptoms, but again, we need to do this big trial to really answer that question. I mean, anecdotally, people who go on this will describe that when they go into ketosis, they describe sort of having more energy and suddenly feeling vitalized and having access to energy for the first time in years, for example. So that's a very anecdotal description. And I guess what I'm interested in is that maybe the energy change is what comes first. So maybe having more energy in bipolar depression happens before you feel less depressed. So maybe just having more energy precedes your mood improving. So we're interested in looking at that carefully as well. So yeah, but it's still, I mean, I guess what I should say, Matt, it's so early stage. The data is so early stage that we can't answer any of these questions with any certainty.
So clearly, if anyone went to their doctor and said, I want to try the keto diet for mood, the message is wait for the data. The impression I'm getting talking to you, Danny, is that there have been anecdotes for years, and it's only now that we're beginning to put rigorous science into the mix to put these claims to the test. Why is this? I mean, why has it taken so long? Well, firstly, for us to start thinking about treatments for mental health problems that aren't directly, if you like, targeting the brain, that they're looking at the body as well. And why is it that the keto diet specifically has taken so long to get put to randomized trials?
So that's a massive question. And I've thought about that a lot. And I think there's been a culture in psychiatric research that has been overly focused on psychopharmacology for 30 years and monoamine hypotheses, etc., etc. And clearly no one ever believed that was the only explanation for mental illness. But a disproportionate amount of research funding went in that direction, I think, and new or slightly left field ideas were often difficult to get funded. That was our experience just 5 years ago. Like, and this is from the National Institute of Health Research in the UK. The panel thought that there was just so little evidence to justify a small mechanistic study. So I think there's a culture, that culture over the last 20, 30 years has not been helpful. You know, a lot of the mental health has traditionally been underfunded. So people look to pharma to fund a lot of the research, which is reasonable in lots of ways. And I just think maybe the patient voice has got bigger recently, that people are starting to, you know, it's an old adage, like you should ask your patient what helps them, and then, you know, think seriously about that and, you know, encourage them to do more of it. So I think the patient voice has become more prominent, I guess, through the internet and social media and all of these things. So we've had to take note of that properly. And I think there's just a bit of space to do things more creatively. You know, I'm going to mention Wellcome, Niall, because I think Wellcome have opened the playing field with the amazing sort of high risk, high gain funding opportunities that they've been prepared to fund in recent years. I think that's really changed the landscape in a positive way. Previously, it was very hard to get anything that was remotely left field funded, but that's sort of no longer the case. Not completely, but, you know, it's been an interesting change in the last 3-4 years, I think. So it's lots of factors, and I don't want to be too critical of the previous generation of researchers, but I think somehow people got caught up in only thinking that mental illness was above the neck, really. That obviously now we know that these are whole body disorders, and that by studying the whole body, we can think about new treatment approaches.
I'm tempted to ask if you're encouraged at all by the FDA and Robert F. Kennedy Jr.'s interest in non-traditional approaches to mental health. I know he has expressed that interest with some concerning enthusiasm, but enthusiasm nonetheless, and so may open new opportunities for funding and more trials, perhaps at a larger scale. And I was just curious how the metabolic psychiatry industry, as it were, perceives that attention, and how, you know, I'm sure there's some appreciation, but also some concern. But I also don't want to put you on the spot if that might.
I don't mind. No, I think I'm very happy to get. So my view of this, and I think almost everyone has pointed out that he shouldn't have used the word cure when he communicated that sort of stuff. So he was obviously over enthusiastic in his use of language, which isn't particularly helpful, is it? But I think there is something in this, and we do need to tackle it, but we need properly designed research. So it's always about striking that balance between enthusiasm, getting funding, and doing high quality science. I think that's the tension, really. I haven't been too involved in responding to these kind of things because I feel that as a researcher, I just need to focus on science and doing it well. But, you know, the metabolic psychiatry is a very dynamic community now. You know, people are really enthusiastic about communicating the potential, which I think is probably a good thing. But we just need to tread a careful line around not going beyond the evidence as it exists, is my diplomatic answer.
So you, having given that answer, I'd like you to project yourself forward 10 years' time. And do you think that in 10 years we will be talking about dietary and metabolic treatments as a mainstay of mental health care in the same way that medication and psychotherapies are now?
I don't see why not. It's a very reasonable ambition. Our patients want not to get fat and not to get diabetes, and they want to have energy and they want to sleep well. So you have to look at dietary approaches for that, especially in modern society where there's just too much sugar everywhere and all of these kind of other problems. So yeah, I think even just to improve physical health outcomes, to stop people becoming obese, that's a very reasonable ambition. If you're a young person with a first episode psychosis, it should not be inevitable that you're going to gain 10, 15 kilograms in the first 6 months of your treatment. That's not reasonable. So we need to tackle it just for that reason alone. But let's see what the evidence is. If these approaches like nutritional ketosis work, then definitely we need to scale it up, train up mental health dietitians. Community mental health teams in the UK are excellent. They've got a really broad range of expertise. Community nurses, occupational therapists, clinical psychologists. I don't see why we couldn't have nutritionists involved in community mental health teams, really helping patients with what patients actually prioritise. So why not have nutritionists in a community mental health team? That would seem to be a good investment from my point of view.
Thanks. And when do you expect to get the data from your trial? When do you get the readout from that?
2031.
Okay, well, maybe you can come back on Lancet Pulse then and discuss it.
Yeah, absolutely. No, these things, I'm discovering doing clinical trials is very hard work. Doing them well is very hard work, and it takes a long time. So we'll have to be patient for our trial. But, data is coming from other areas as well. Yeah, I think the field is definitely moving fast.
I was just going to say, we're very appreciative of your diligence. Obviously, there's no point in getting this message out there if it's not the right message with a robust data set behind it. And so,
yeah, I was going to say that the two messages which I'm getting from this podcast are follow the data and remember that the head is attached to the rest of the body.
Yeah, seems reasonable.
So I think that we've covered everything. Thank you very much, Danny, for your time. Thank you, Matt. And thanks to you, the listener, for downloading and listening to this Lancet Pulse podcast. We do hope that you will join us again next time. But for now, goodbye.
Thanks for listening to the Lancet Pulse. If you enjoyed this show, leave a rating or a review on your favorite platform and subscribe to stay updated on our latest episode. The editorial team includes Chloe Wilson, Ben Abbott, Matthew Gilbert, and Jonathan Pym. This show is part of the Lancet Group podcast offering, and it's produced by Matteo Simonetti. Thank you for being with us.